Good morning and welcome to the Medicaid monthly virtual meeting. We will just give it a minute to, as we clear the wait room to let folks join, but we appreciate you being here today. Good morning. Welcome to the Medicaid monthly virtual meeting. We appreciate you taking the time out to join us today, either live or perhaps you're watching a recording. We were giving it a moment for the wait room to slow down, but it looks like it has. So we'll go ahead and get started. My name is Veronica Judy Cecil. I'm the Senior Deputy Commissioner here with the Department for Medicaid Services. We have another really great full agenda for you all today. We'll be giving our regular update on Medicaid renewals. We have an update on the 1915C Community Health for Improved Lives and Development waiver, also known as the Child Waiver. We have an update on the 1915I RISE program. An update on our reentry, the status of our implementation of our reentry program. We have a wonderful update on Kentucky Medicaid self-measured blood pressure cuffs. And then our regular monthly, our Healthy Kentucky Home Spotlight. We have Dr. Judy Terrio here talking about smoking and vaping, prevention and cessation. And then lastly, we'll give you an update on the federal law changes that related to House Resolution 1 that was recently passed and signed into law. So we will get started and I will kick it off to the next slide, please. All right, we'll talk about Medicaid renewals. Next slide. This is the snapshot that we present every month just to show the overall trend as we've moved out of unwinding and the restart of renewals. We're just into regular, normal eligibility and enrollment processing. As you can see, we've stayed very steady. There's a little blip at the end with August and July and August as we start to do eligibility enrollment and redeterminations that no longer have the public health emergency unwinding flexibilities. And we'll be talking a little bit about that. Next slide, please. Looking at the most recent month of renewals, which was July. So those were renewals through the month of July. This was the first month that we also started child renewals. One of our flexibility, if you recall, was that we were allowed to automatically renew children through the public health emergency unwinding. And so, but now they must go through an actual redetermination. So those have started with the month of July, and those renewals will happen over the next 12 months. So for July, for all populations, we had 48,216 renewals. We were able to approve 42,816. The majority of those were through what we call a passive renewal, meaning the member had to take no action. We were able to go out and check those databases automatically and determine them eligible. So the majority of those approvals have been done passively or also known as ex parte. You'll hear folks call it as ex parte. And so that's a nice, really large number, over 80%. And then for terminations, we did have 4,944. And then at the end of July, we had 412 cases pending. By pending, that means that the information's been returned and the state had not had yet a chance to process it. So we always continue those cases until the state makes those decisions. The extended bucket I left on here and it says 0. And that is just to draw attention to the fact that during the public health emergency unwinding, we did have a flexibility to extend folks up to 1 month or up to 3 months if they were long-term care or 1915 seat home and community-based waiver services waiver enrollees if they had not returned their renewal packet. So it was an active, it required an active renewal. We sent them a request for information. They did not return it by the end of their renewal month. We were allowed to automatically extend them. That flexibility is now ended, so we are not permitted to extend anyone, and that started with July renewals. What that does mean to the member is that if they did not return their information by the due date, by the end of the month, then we had to go ahead and terminate them for lack of response. Next slide, please. This is a snapshot of by age. We've got a lot of interest in tracking the children in particular. So we are going to start sharing this by age so that we can reflect the children under up to age 18. So this is all ages, and the children are the blue and the orange are the two age groups that make up children for us. So on the far right there, you'll see the blue and the orange are specific to that. We had 8,423 approvals for children in those age categories and 950 terminations, which we do not like to see. We want to make sure that children are staying covered if they are eligible for Medicaid, or that they move over to a qualified health plan on the exchange if no longer Medicaid eligible. So we are tracking those numbers. We're making sure that we're doing a lot of outreach to families that are, that have children that are terminated, that they're aware of what's happening and what their options are. Next slide, please. This is what we call by type. And by type, the far right there is that passive that I talked about. That means we were able to actually go out, check those databases, automatically renew the individual because we had all the information we needed and verified. So that's that large bucket that's on the far right there. The middle bucket means that we attempted that, but there was still information that could not be verified. So we sent an RFI or request for information. So that's that middle bucket and shows you how many we were able to go on and approve and that were terminated as a result of an RFI being issued. And then the far left is those active renewals. Those are ones that we just cannot do passively. It requires too much information, and it drops to what we call an active renewal. And there are the numbers for those who, and these are specific to children who went through an active renewal. Next slide, please. And then we've gotten questions also once they were terminated, what was the reason for their termination? And this is what this slide is reflecting. That top bucket is for for children who were terminated because we did not get a return form. The middle one is they returned the form, but we determined them ineligible. So they truly are not Medicaid eligible at the time of the redetermination. And then the bottom bucket is for other reasons. The primary reason for that is generally that there's a request to disenroll the child. So there are reasons why families may want to just go ahead and disenroll the child, either put them on their employer insurance, or they have other coverage. So that's that bottom bucket. You will see that a large number, and we found this through when we restarted renewals for the adults, that the majority of terminations are a result of failure to return the form. And there are things we are trying to do to try to make sure that folks understand that it's always best to go ahead and return the form so we can make a determination of ineligibility. That way we know for certain that the individual is no longer eligible. And for children in particular, they have a higher income level that allows them to be eligible that is different from maybe their parent or other family members. So we always encourage families with children to send in the form to respond to the request so that we can determine whether or not the child may still be eligible, even if other members in the household are not. Next slide, please. We also asked just what the projected caseload for children is over the next 12 months, and this is what this is reflecting. In the blue are total cases, and in the orange, the bottom line is for cases with children. So you can note that in November and December, we generally have a lower caseload number because of the holidays and fewer days for processing renewals. So we do have lower numbers both in those holiday months as well as in the summer. So this is the projected caseload. This is subject to change. It changes every month as new people come on or come off. And so, that could change slightly, but this is the current snapshot of the caseload across the next 12 months. Next slide, please. So just a reminder to folks that we have restarted annual renewals, and it is every 12 months. Most Medicaid members are subject to an annual renewal. There are some that are not. They could be categorically eligible. For example, if the individual is pregnant, then they may qualify just based on them being pregnant. Foster kids are categorically eligible. If they're in foster care, they're automatically given Medicaid coverage until they are no longer in foster care and they do not go through an annual redetermination. But what we're really trying to make sure folks know and remind them is that it's really important to keep information updated with us. So the address, a phone number, an email address, any way possible that we can communicate with a Medicaid member. We really like to have those different options and for it to be current. So we do encourage anytime that a member has changed their contact information to make sure it gets updated with us. There is a renewal form that's sent at least 45 days before the due date. The way our process works is we start the renewal 60 days prior to. So for example, for the July renewals, we started the process in early June to go out and do that passive renewal. And then if we can't passively renew someone, we drop them to that request for information or an active renewal. So that happens in the first couple of weeks of the month before, and then we send out that notice. If they don't respond about 15 days prior to the due date, then we'll send them another reminder. We do a lot of outreach around this, and I'll go over some of that in a little bit. But we are always trying to reach folks that are having to return something to us to make that determination. Members have access to their renewal month by either getting on Connect to this in their self-service portal. They can call Connect to find out when their renewal month is. And then providers, every Medicaid provider has access to the member's renewal date in Kentucky Health Net, and they can access it that way. So again, asking folks to return information if requested as soon as they can, and definitely by the due date. If coverage is terminated and they reach out within 90 days to submit that information, we are able to reactivate the case. If it's over 90 days, they do have to go through a reapplication, but we try to use the information we already have available. It just has to get verified. Next slide, please. So I talked about some of our outreach efforts, and it's multi-pronged. The state does calls, texts, and emails and of course mailed notices to folks, but we really do try to reach them any way possible to communicate that they're going through a renewal. The managed care organizations, for those who have managed care organizations, they are also trying to reach those members. They get a file every month that tells them who's going through an active renewal. And they send letters to try to help folks understand where they are. I know some actually send letters to say, you're good, you were automatically renewed, there's nothing further you have to do. So they are also trying to reach their members. I'm sure members sometimes get a little tired of hearing from both the managed care organizations and the state. But again, we want to keep people covered, and we think it's a priority to stay in touch with them. And then particularly with the restart of child renewals, we've been working with the Friskies, the Family Resource and Youth Services Centers in all 120 counties, and the schools, and trying to get information to parents and guardians at the school through the school resources that children are going through a renewal now, and to make sure they're keeping an eye out for that and keeping their information updated with us. And then we have the fabulous connectors all across the state and all 120 counties available to assist anyone with an application or a renewal. And we encourage folks to access that help. You can get in-person assistance if you're somebody who really wants that face-to-face engagement, or they can also assist on the phone. Next slide, please. We always promote all the wonderful communication tools we have out there available on our website. It's that medicaidrenewals.ky.gov website. So all of these can be downloaded and shared. We're happy to have people pull those off and utilize them. And we try to keep them updated. If there's new or changing information, we try to keep those updated. So please access those communications. And next slide, please. We created one specific for the child renewal, restart of renewals. So we have just some that are specifically for child renewals, and we do encourage you to go out there and utilize those as well. We have a toolkit available around child renewals with frequently asked questions, and just a lot of information to help folks as they're navigating the restart of child renewals. Next slide, please. I also want to remind folks, we did create a member toolkit, and it is available out on our website. It helps our members understand how to navigate the Medicaid program, how to access services, how to get help if they need it. So we're still encouraging folks to utilize that as well. Next slide, please. And this is just a snapshot of what our Medicaid renewal website looks like. All these meetings are recorded and posted there. We still have frequently asked questions, all of our CMS monthly reports that we're still required to file about each month's renewal, an update based on any processing within 90 days after the renewal month. Those are all still posted on the website there. So if you really want to take a look about a particular month in a little more detail about the renewals that happened that month and how they were processed, those reports are posted on this website. Let's see. I've got a couple of questions I'm gonna respond to. And does passive renewal include having a working address, phone number, and email? So what we ask is that members keep their contact information updated. Passive renewal does have a way to go and verify information. I'm not sure if that answers the question, but I see actually one of our staff, David Berry, the passive renewal process will use the household address, phone number, and email that are in the application case file. Thank you for that, David.
And I could add a little more color briefly. When someone puts in an address, it'll ping it against the USPS to make sure that it is a real address, and actually they'll make a suggestion and default to the address that truly exists. No, we won't know if they've moved. That's always kind of a tough thing. We're sending the same email out to people, or not email, but the same mail to people who aren't there anymore. So that's why we really need you all to push with us to get people to keep us updated.
Yes, and we do go out before we run the renewal. We do go out and check the national change of address database and try to update. And our managed care organizations also assist us with updating addresses. And so if they have a more current address, we're allowed to consume that information. And then we do try to verify it. So we do try to update those before we actually run the renewal and before we send the notices out every month. But that's a great question, so thank you. All right, next slide, please. I do want to give also an update. We can't forget our state-based exchange connect and qualified health plans. And so we wanted to give a kind of an update on specific to the marketplace, and David's on to help answer any questions. One is, and we'll be talking about House Resolution 1 later on in the presentation today, but there was a kind of a significant change as it relates to eligibility, and that has to do with immigrants who are not eligible for Medicaid based on immigration status and have income below 100% of federal poverty level. They'll no longer be eligible for those APTC tax credits. We did want to make folks aware of that. There are enhanced tax credits. So there's a new educational tab and a fact sheet on the KHBE website. And we have renewed our push to emphasize the value of obtaining, using, and keeping health insurance, even if or when the monthly contribution toward the premiums rise. Excuse me, which is what we are expecting to see with the tax credits going away, with the enhanced tax credits going away. And then we really want folks to know that the open enrollment will be November 1st, 2025 through January 15th, 2026. No changes to the passive renewal and auto re-enrollment process. So those will remain the same for the next plan year. We also, I think what has been noted here, there will be many more plans that are HSA compatible for folks. All right, next slide, please. And David has shared the link to the exchange in the chat. Thanks for that, David. All right, so I will turn this over to Dr. Hoffman.
Hello, hello. So glad to be here today. I'm going to go over our child's waiver, and CHILD actually stands as the acronym for this waiver. It's a 1915C, Community Health for Improved Lives and Development Child Waiver. Next slide. I've spoken several times on the monthly forum, but I just wanted to go over this just one more time, that the child's waiver is part of a Families First continuum. So it is one component of a multi-component, multi-comprehensive initiative that our whole entire cabinet, even folks outside of our cabinet, are working on. So just wanted to go over this just real quick. As you may or may not remember, we have a SHINE grant that we applied for, and that's strengthening health integration for Kentucky students. And we were able to get approved and obtain funds for the SHINE grant. We also have Kentucky Cares. That was a grant that we applied for continuity of access and resources to essential services. And we were awarded that, and we are waiting, I believe this month we are supposed to have a kickoff with cohort 2, the combined cohort 1 and cohort 2 to get started. So that'll be this month. We also have the child mapping tool that we've been working on, which is Children's Health Initiatives. We're very proud of this child mapping tool, and it helps us to leverage across the cabinet, even outside of the cabinet, things that are going on for children so that we can leverage each other's programs and blend and braid funds and fill in gaps for our children here in Kentucky. We have funding modernization that we're currently working on, which is a restructuring of Medicaid payments for medically necessary treatment services. And then you will see the next bullet with the hands holding as a heart, high needs service delivery, which is the 1915C CHILD, C-H-I-L-D waiver that is designed to meet the child-centric care support services, housing, custody, and placement, and other health-related social needs. You will see our futuristic and hopeful child state plan amendment that will be in the future hopefully. It's a state plan amendment that will be to help us also locate appropriate resources and housing for children and youth in need of placement and services. So based on this graphic, the first three have been completed. We're in the middle of the fourth, and the child's waiver is the fifth bullet. I just wanted to remind everybody of that. Next slide, please. So again, what is the 1915C waiver? The child's waiver is a new Kentucky Medicaid program designed to help children and youth with significant behavioral health or developmental challenges get the services that they need, and to assist them in staying in their home and in their own home and community and their own schools. We want to serve the most complex youth with the most complex needs, focus for children and youth stepping out of a psychiatric or an inpatient care type of facility and out of home placement due to requiring intensive behavioral health and residential support needs. This child waiver could also include or does include clinical therapeutic services designed to foster a step down approach coming from the highest level of care in order to return home to their own home and their own community in the least restrictive environment. Our anticipated implementation date, like to get started with our implementation, is sometime around January of 2026. Next slide, please. Who does the child waiver help? It's those children that are under the age of 21 with significant behavioral health or developmental needs, Kentucky children, youth who need a similar level of care to what will be provided in a psychiatric inpatient facility or an intermediate care facility for individuals with intellectual disabilities. The acronym for that is ICF-IID, or hospital type of setting. And we also have to be committed to CMS that if they're in a C waiver, which is a home and community-based waiver, that they can be safely supported at home or in their community with the right supports and services. Next slide. Okay, what is the status and next steps? So Kentucky public comment period has been completed. Responses to the public comment were compiled, reviewed, and approved by executive leadership. We did submit to CMS yesterday afternoon, so 8/20/25. Also, responses and comments were posted to our website just about an hour ago. So we just changed that slide before we came on. We are working simultaneously to maximize the time that we have before January. So we've already drafted regulations for completion, and that is 907 KAR 2.720 for policy, program policy, and 907 KAR 2.725 reimbursement provisions for requirements. I do want to remind everybody, if you're a parent, advocate, family member, provider, that we have been for quite some time having up to 6 regs for 1915C waivers. So this one is going to go back down to 2. So it'll kind of be like the old way we used to handle the regulations for the C waivers. So there'll just be 2. CHFS continues to develop systems and procedures for operations and implementation. So a lot goes into systems changes, implementations related to needed contracts, those kinds of things, policies and procedures in general. Just wanted to let you know that we are working on all of this simultaneous. Next slide, please. Oh, and I'm going to turn it over to Ann Holland with the Department of Behavioral Health and Intellectual and Developmental Disabilities.
Thank you, Dr. Hoffman. As she said, I'm Ann Holland. I'm an executive advisor within the Commissioner's Office in the Department for Behavioral Health, Developmental, and Intellectual Disabilities. And I am also, for our department, the 1915I Project Director. So next slide, please. Just a quick recap of 1915I RISE Initiative. It is a state plan amendment and home and community-based program. The target population is active Medicaid enrollees who with a primary diagnosis of serious mental illness and requiring assistance in at least 2 functional domains. DBHDID is administering on behalf of DMS to certify providers and ensure compliance with regulations, and the services are provided up to those standards. So we do certify, and once we certify providers, they're able to enroll in provider type 51 with Medicaid, which is the 1915I RISE. and then render the services. And then really quick, there's 10 services to the benefit, and they're listed here on your slide. Next slide, please. Just to give you a quick status update, the 1959 RISE staff continue to work to certify and enroll providers. We began onboarding processes July 1st of this year. We held an outreach webinar on July 22nd, which is recorded and can be found on our website. And beginning September, we'll be hosting office hours at 3 p.m. on Mondays and Wednesdays. It's a standing meeting or that people can join to further assist interested agencies in certification and enrollment to render services to individuals. We need more providers to join the RISE initiative, complete the training, and submit their certification packets in order to adequately serve participants. We're turning our efforts to reaching out to individuals who are in process with their trainings and offering assistance with the packet development process. We ask for your assistance in raising awareness and program amongst providers or enrolling yourself. And that's all I have. Thank you.
It looks like it's my turn. Good morning. My name is Kristen Schroer. I'm one of the behavioral health specialists within the Department of Medicaid. I'm giving the reentry status update along with our CAA. They kind of go hand in hand. Next slide, please. So our reentry program, just as a recap, is for our adults and youth who are already eligible for Medicaid if it weren't for incarceration. This is for our Department of Corrections, our state prisons, and for DJJ, our youth development centers. The services for this program is going to be case management 60 days prior to release, and then up to 12 months post-release. Medication assisted treatment, so both the counseling and the medications, 60 days prior to release as well. And then a 30-day supply of any required medications or even durable medical equipment upon their release. So currently our monitoring protocols have already been improved, a systems deployment for the future state. This is a very big lift, all these systems that go into this. So that's currently in progress. We have successfully gotten DOC and DJJ enrolled with Medicaid as a provider type 53, which is strictly just for our reentry organization. And then the program design for the pre-release services is ongoing. It includes work with DOC, DJJ, Department for Community-Based Services, BDID. We just have multiple partners, and we are just continuing to collaborate and communicate with them in moving forward with our implementation. Next slide, please. Then there is the CAA, which is our Consolidated Appropriations Act. So while we were working on reentry in the beginning stages, CMS came out also with our CAA. It's Section 5121, required for states. This is for our youth who are Medicaid eligible at incarceration or found to be Medicaid eligible during placement. It's for under age 21 or for former foster care youth, ages 18 to 26. The settings is going to, for now, is going to be our state prisons and the DJJ Youth Development Centers, the YDCs. This will be for screening and diagnostic services. That includes medical, dental, vision, behavioral health screenings, diagnostic services, 30 days prior to release, along with case management starting 30 days prior and for at least 30 days after. So the state plan amendment has been approved for CAA, one of the early states to be able to get this in and get it done for both the targeted case management and the screen diagnostics. The alternative benefit plan SPA is currently in progress as well. We had a CAA grant awarded. We are going to be having our kickoff call this week to get that started. And the hopes of that grant is just to help our partners in this build up all of our systems and staff that we are needing to be able to successfully implement. And I believe that's all I have for the update today.
Hi, my name is Justin Derringer. I'm the Director for the Division of Healthcare Policy, and I want to talk a little bit about Kentucky Medicaid self-measured blood pressure cuffs. Next slide. So, how to obtain those? The first step is through our Kentucky Medicaid providers. Kentucky Medicaid providers will see a Kentucky Medicaid member to ensure medical necessity for a blood pressure cuff. Once that medical necessity is determined, that clinician, which may be a physician, physician assistant, APRN, maybe a different clinician, can sign an order for that blood pressure cuff or monitor. Next slide. The clinician order is sent to a hospital if that individual Medicaid member is an inpatient at the hospital. The hospital usually fills that order, does all the education to the member, and shows them exactly how to use that blood pressure cuff. If they are not an inpatient in the hospital, then it is sent to a medical supplies, equipment, and appliances provider. The acronym for that is MSEA. That is formerly known as a DME or durable medical equipment provider. Next slide. So our medical supplies, equipment, and appliances providers are all over throughout the state. The clinician's orders are sent there. That provider usually is the one that, once after receiving the order, reaches out to the member to set up a time for them to come in. Sometimes the member may go directly from the provider if the provider gives instructions on where to go. These MSEAs are also able to mail out these supplies if a member's not able to get to the provider in time. So we provide, in addition, we provide areas where these providers are, and that is right there listed. We have those providers for our fee-for-service members. If our members are MCO members, then they reach out to their particular MCO to see which MSEA provider is in their network. Next slide. The MSEA usually fills those orders most of the time same day when they're in stock. Sometimes it may take a day or two, but they usually deliver those supplies through the mail or have the member come in. Our MSEA suppliers are also the ones that usually educate the member on how to use the blood pressure monitor or the blood pressure cuffs, and most of our pharmacies are MSEA providers as well. Next slide. So we have three different covered devices. We have the blood pressure apparatus with the cuff and the stethoscope, as most people see traditional blood pressure cuffs. We also have a dialysis blood pressure cuff, which hooks into a dialysis machine. And then we have an automatic blood pressure monitor, which automatically monitors your blood pressure as well. No prior authorizations are required for any of the three devices that we cover currently. Next slide. So the Kentucky Department for Medicaid Services, in addition to providing those three devices, we also cover remote patient monitoring for automatic blood pressure devices. So clinicians can review and monitor their patients at home with their blood pressure that are having blood pressure issues. And we also cover patient education that's either provided by the hospital or usually the MSEA. Can also be provided by a clinician in some instances. Next slide. We also were able to create two unique guides to obtaining blood pressure cuffs. These guides cover members on how to obtain blood pressure cuffs, but they also provide guidance on providers how to bill or how to order blood pressure cuffs. One of those is for fee-for-service or traditional Medicaid members, and the other one is for members that have managed care organizations. So both of those guides can be found at that link below there. Next slide. If you have any further questions on blood pressure cuffs or anything else related to that area of interest, please give us email Division of Healthcare Policy at kentucky.gov. Thank you.
Hello, everyone. It's time for our Healthy Kentucky Home Spotlight. And this month, we are talking about smoking and vaping, either prevention, cessation, and secondhand smoke. So next slide. During the month of August, we're focusing on smoking and nicotine products. That also includes dip, and other things you might smoke or chew or vape. Smoking and secondhand smoke exposure causes over 500,000 deaths in the United States each year, and it can harm every single organ in your body. Both smoking and vaping can increase your risk of heart disease, cancer, diabetes, stroke, other health problems, and just modest changes in your routine can help. So, next slide. More than 16 million Americans had at least one disease caused by smoking in 2022, and that is more than 5 states of Kentucky, more than the people in Kentucky times 5. That's an enormous amount of people. In Kentucky, more than 20% of high school students reported vaping, and 17% of Kentucky adults report that they currently smoke cigarettes. So we do have an issue in our state with nicotine. So next slide. So it's a three-prong attack. We want to prevent people from initiating tobacco use, especially the youth and the young adults. If you already smoke, we'd really like to help you stop smoking and assist you with nicotine replacement or other things that will help stop smoking. And then the third aim is to help protect people from secondhand smoke. And that could be anybody, but also people that can't protect themselves, such as children, infants, the little ones in our communities. So next slide. So first we'll talk about preventing getting hooked, if you would. And most of the time, people who use tobacco as adults, they started in adolescence. I used to smoke. I started stealing cigarettes from my parents when I was 10 or 11 and was an active smoker by the time I was 15. Now, everybody smoked back then, and it was easy to get cigarettes, easier than it is now. But as a rebellious adolescent, my thought was they can't tell me what I can't do because they do it themselves. So my role models all smoked. But most of the time you get hooked when your little brain is not thinking clearly, and you're an adolescent. They looked at adults that smoked, and most of them that second bullet there smoked before they were 18. In 2024, 2 in 5 students who had ever used tobacco products currently still use them, which is a lot since it's illegal for them to get it. So they have to go through a lot of hoops to get their tobacco. And then flavorings in tobacco really make them more appealing to the youth. And when they looked at high school and middle school students, those that currently either used e-cigarettes or used nicotine pouches in the last 30 days, the vast majority of them used a flavored nicotine product. So, one of those, fruit flavored or whatever products that's either in the e-cigarettes or in the chewing tobacco. Next slide. So the providers of the nicotine are really trying to get kids hooked early by developing flavors that they will like, and then they'll be hooked on it and they won't be able to stop. There's some myths out there about e-cigarettes. One of them is that e-cigarettes is just harmless water vapor. It's not going to hurt anybody. Well, that's actually not true. It is an aerosol. It has nicotine. It has toxins in it. It has heavy metals. The flavored products also have a chemical called diacetyl, and that's the chemical that you've heard of kids or even adults vaping and then all of a sudden having really horrible lung problems, and that's from that diacetyl, and it can literally kill your lungs and you would have to go on a lung transplant list. So most of the time it's not going to hurt you, but if it does, it's going to be very serious. I've also heard e-cigarettes can help people quit smoking. People that currently smoke say, I'm going to switch to e-cigarettes. That has never been true. It's never been proven. And in fact, e-cigarette use among youth leads to smoking in the future. So it's kind of the opposite effect. Next slide. E-cigarettes are safe. Well, we already talked about that they're not safe. They are not, most of them have nicotine in them, which is a toxin itself. It also has the heavy metals and things that we talked about. But if you're an adolescent, your brain is still developing. And when you're putting those neuroactive chemicals into your body, it is affecting the developing brain. And it's shown that kids can get depression, they can have trouble in school, trouble with sleeping. So they can actually have side effects of this that adults don't necessarily get. And then we talked about some people say they're not addictive, but they are. Anything with nicotine in it is addictive. Big tobacco might not own these companies, but they invest heavily in the companies because this is a way to get kids hooked. And so they will move on to the big tobacco products later on. So next slide. So kids are different from adults. We do have things out there to help kids quit vaping and smoking and chewing. And so this is a website that you can go to, My Life, My Quit. It's geared towards adolescents. So it's more on their level and it helps them to quit smoking. So this is a resource that you can have later on. Again, they're kids, so what works for adults is not necessarily going to work for kids. So we have to develop things just for them. Next slide. When talking about people that smoke, what are the benefits of quitting? Well, you can actually have effects right away when you quit. After 12 hours, your body is free of nicotine. You're still having those cravings, but the nicotine is out of your body. After 2 days, your sense of taste and smell improve. Your clothes will smell better. Your house will smell better. I remember this when I stopped smoking. I remember, and I was like, oh my gosh, why does it smell different? And then I realized later that that's why, which, was not good. It's like, oh my God, that's what it smelled like before. But I do remember noticing that. Your blood pressure improves within a month. Your circulation improves within 2 months. Blood pressure will return to normal by a year. So you decrease your risk of heart disease and cancer over more years. So it's really worth quitting, and you will see some results right away. So next slide. So back to our healthy Kentucky home. How can this help you quit smoking? Well, a lot of people that smoke are afraid of gaining weight when they quit. And it's true. You're used to putting something in your mouth all the time. So you're going to want to do that when you quit smoking, and you're going to do that with food. So one thing to do is have your healthy fruits and vegetables ready, prepared for you. If you get a craving, eat a carrot stick, eat something healthy, have those healthy things there. You don't want to rip open a bag of chips or something. You want to get your 2 servings of fruits and vegetables a day, and this is how you can do it. Next slide. Exercise is another way to fight cravings, and this has actually been scientifically proven to help cravings. So if you're having a craving for a cigarette, you can exercise. You can take a walk around the block. You can do some push-ups. You can do some jumping jacks. You can do something, get your mind off of it, do something else with your hands. And then it has proven to help decrease those cravings. And then you're going to improve your heart and your lungs and your muscles while you're at it. So next slide. And then, of course, the third thing is engaging. So you want to build your smoke-free team, surround yourself with people that don't smoke, and that will help you not smoke as well. If you're surrounded by people that smoke, you should still try and quit yourself. It's just going to be a lot harder, but you want to engage. So next slide. Everyone on Medicaid has access to medications at no cost to you to help quit smoking. We also pay for the nicotine replacement, like patches and gums, that you can use to help you quit smoking. The medicines really work. And so when you're ready, there's things out there that can help you. So next slide. Secondhand smoke is a lot worse than people originally thought. In children, secondhand smoke can cause respiratory infections, ear infections, asthma attacks. It can even cause SIDS in infants. And part of the upper respiratory issues is because the baby's body makes mucus to protect its airway. So the body is reacting to the smoke, trying to protect itself, but then that mucus, will cause the ear infections and all of that other stuff, the asthma attacks. And so you definitely want to keep secondhand smoke away from kids. Since 1964, about 2.5 million people who did not smoke died from health-related issues caused by secondhand smoke. And adults who are exposed can still get coronary artery disease, strokes, lung cancer, other types of cancers and diseases, because they're exposed to that secondhand smoke. And my grandmother, who never smoked, died of bladder cancer that was directly related to secondhand smoke exposure. And so we do want to cut down putting that smoke into the atmosphere. We want to protect our kids and protect people that can't protect themselves. And so this is very important to think about. Next slide. So to sum it up, our Healthy Kentucky Home, we want to try and eat at least 2 servings of fruits and vegetables a day, exercise 30 minutes 3 times a week, and improve our engagement with others. So link out there, talk to others, walk the neighborhood, find out what's happening. So next slide. These are just some helpful websites about smoking, quitting smoking, things like that. The one for adolescents is on here as well, to help get you started in your journey to quitting smoking. Thank you very much. We'll see you next month.
Thank you, Dr. Terrio. I always enjoy your presentations, and thank you for sharing your story too. We really appreciate it. So now we're going to move into the discussion of House Resolution 1, which was passed by the 119th Congress and signed into law on July 4th. Next slide, please. I do want to say that this is a massive piece of legislation, and we are not going to be able to get into every single detail, but what we tried to do in the presentation today is just start the conversation about some of the key provisions that will be having to monitor and implement over multiple years. And as we move forward with identifying the requirements and implementing them, we will keep you all updated as we come upon an effective date and what our plans are. So we'll try to keep you guys updated on that as we move through implementation. But as most of you all probably do know, there was a major piece of legislation signed on July 4th that has not just Medicaid provisions in it, but also affects SNAP and TANF and other programs related to the cabinet. But today we're going to focus specifically on the Medicaid provisions. Next slide, please. So some of the key eligibility changes that we want to make sure folks are aware of. One is the first listed there, which is that we will be limited in being able to provide retroactive coverage to Medicaid expansion members to 1 month and limited to 2 months for traditional Medicaid members starting on January 1, 2027. Currently, we could go back 3 months if they were eligible and they had medical bills, but now we will, starting January of 2027, be limited to 1 month retro for expansion population and 2 months for traditional. The next key change is to eligibility for certain immigrants who are lawfully present. That change will be October 1st of 2026. The legislation also requires that Medicaid expansion members have their eligibility reviewed every 6 months, beginning in January of 2027. We talked previously in this presentation of our annual 12-month redetermination, but for expansion members after that date of January 2027, we'll have to redetermine them every 6 months. Also, Medicaid expansion members from age 19 to 64 will be subject to work requirements starting, that's effective December 31st, 2026. So January 1, 2027, we will have to start checking for compliance with the requirements upon enrollment and upon redetermination. There are some populations exempted from that. We don't have all of the information right now. It does clearly exempt disabled and elderly individuals, but we are awaiting more CMS guidance around this. The law requires CMS to issue a final rule in June of 2026. So we don't know when we're going to get that additional guidance to be able to prepare to implement this. It'll be a really short turnaround time if we don't get the information until then. So in the meantime, we know there's lots of questions about this particular provision. We don't have a lot of answers right now, but we will keep folks updated and on what those changes are and how they'll be implemented and how it affects people individually. There's also a new cost sharing requirement for expansion members, and that begins October 1st, 2028. That's for anyone over 100 to 138% of the federal poverty level. There are services that are excluded from that, and that includes primary care, behavioral health, that's substance use disorder services, family planning, the emergency room, long-term care, and services provided by certified community behavioral health clinics, federally qualified health centers, and rural health centers. Next slide, please. There are also some changes to provider reimbursement that's really going to impact Kentucky. And again, we are still waiting for some CMS guidance on really the details of this and how it will truly impact us. We're trying to do some forecasting as best we can with the information we have available right now. But this will definitely impact Kentucky as we do leverage provider taxes to help increase provider reimbursement rates for certain providers. And we have what's called state-directed payments, and that allows us to tell the managed care organizations what specific payment they are to make to providers. So there are changes with both of those. There's a limit on provider taxes going forward. There are no new provider taxes that are going to be permitted with the date of the effective date of the legislation. And then for states that have provider taxes, we have to reduce down to 3.5% by 2034. So this is something the state will be looking at and evaluating its impact to, quality services and access to services. The state-directed payment is being capped at 100% of Medicare. Currently, we can go up to the average commercial rate, so there's quite a decrease there for providers. And beginning in 2028, states that are above that Medicare payment, like Kentucky, will have to start reducing their payments by 10 percentage points annually until they comply with the new cap. There are a couple of excluded providers, and that's nursing facilities and intermediate care facilities for individuals with intellectual disabilities. But otherwise, we are going to have to apply these new provisions to all other provider types. Next slide, please. Just a couple of other key changes, and again, we're not covering them all today, but wanted to go ahead and make sure you were aware of. You may have heard some conversation about a rural health transformation program. This was a last-minute addition to the final version of the legislation. It's $50 billion in funding over 5 years available to the states. There is an application process for a portion of the funds, and that application, we're waiting for additional CMS guidance on what that looks like. But the law requires the funds to be distributed by December 31st, the first year of funds to be distributed by December 31st, 2025. So we're going to have essentially a very tight turnaround time from when we get the guidance from CMS and the application and what's going to be required to when we have to submit it and then have the grant funds to be issued. What we're currently doing is working with various organizations across the state to try to gather input around what is in rural health, what can we do to transform rural health. And, we're really trying to be very innovative because these are going to be one-time funds over the 5 years. And so it has to be something that we can sustain without continued funding. So that is going on right now. We'll keep folks updated on that. There's a provision for a new standalone 3-year waiver for home and community-based services, and that starts in July of 2028. It'll allow states to apply for a waiver that no longer requires individuals to have to meet nursing facility level of care. This is a major shift in the requirements for eligibility for home and community-based services. So we'll be interested in watching to see what all that involves as more guidance comes out on that. And then another provision of the legislation was requiring quarterly checks of Social Security Administration death master file for enrollees and providers effective January 1, 2028. We already incorporate with vital statistics a death master file check. So this really doesn't affect Kentucky very much, but it is a requirement for a lot of states going forward. Next slide, please. I've posted into the chat, KFF has a really great resource that provides all the provisions of the new legislation, and it does it by Medicaid, Medicare, just health in general. So it's very easy to navigate if you're interested in more information about the different provisions and when they're effective. I certainly encourage folks to utilize that. But as I said, as we move forward, any of the provisions that impact Kentucky Medicaid, we'll continue to provide updates on. And we know it's a very changing environment for folks, and we want what we are most concerned with and will prioritize is making sure that our members are able to navigate it and support them as much as we can as we move through those implementations. We are over by 3 minutes, so just a reminder that we are always interested in hearing from you all what you'd like to see in this presentation every month, so don't hesitate to reach out and let us know that. But I don't see any unanswered questions, so I think we'll just close for today and just want to thank you again for taking the time to be with us. Have a great week.